Can you hear me?
Yeah.
Oh, okay. I'm married. I have 2 kids. They are 7 and 10. And I don't know. That's about it. I'm a writer.
Perfect. Thank you for joining.
Thanks for having me.
Ooh.
Go ahead.
Okay. Good afternoon, everybody. I'm Tammy, or good evening. I'm Tammy Aon. I'm a BRCA Strong board member. I'm a 2-time ovarian cancer survivor and a purveyor. I had a preventative mastectomy. I'm also a single mom, and I work in government affairs with the business community.
Perfect. Let's see who's next. Lorraine?
Hi, I'm Lorraine. I live in New York City and uterine cancer, and just, I guess that's it. Shy.
Thank you for joining.
Thank you.
Kamali?
Hi, I'm Kamali. I am a ovarian cancer stage 3C survivor. I am in New York City, as well as Lorraine, and I'm a single mom. And I was a real estate agent before I was fighting cancer, and I'll get back to real estate at some point soon.
Thank you for joining.
Thank you for having me.
Mary?
My name is Mary. I live in Miami, Florida. I'm a breast cancer survivor. I'm a mom of a crazy 4-year-old. I mean, I don't know. I always say in every meeting, I'm happy that I'm able to come in because I learn a lot of stuff, and every little 2 cents, help somebody else. So thank you.
Thank you, Mary. Suzette?
Hi, I had ovarian cancer in 2018, a very aggressive form of ovarian cancer. And they had to it went into my colon. So they had to, in the middle of surgery, they had to remove everything. And then they had to also do colon surgery. They had to bring in a new surgeon. Actually, I'm sorry. Last week they found another cyst, so I'm going back into surgery next week. I'm sorry. So it's a little scary because I don't have anything in there, so it's kind of, they're bringing in another gastrotoc. So it's probably cancer. They really suspect it's cancer, so.
Well, if there's anything we can do for you, thank you for coming on and sharing your story. You can feel free to reach out to myself, Kate, or Tammy. After the call, we'd love to connect with you, and if there's anything we can do, no matter what state you're in, we'd like to be able to help you.
Thank you.
We're here 100% to support you.
Thank you.
Nasha?
Hello, did you hear me?
Yes, hi. We'd like you to do a short introduction on your name.
Hi, I am Nasha. I'm 27 years old, and I'm a survivor of breast cancer, stage 4.
Thank you for coming on and sharing your story. Simran?
Hey, my name's Simran. I am a BRCA1 previvor. I just had both my mastectomy and my total hysterectomy 13 days ago. So I'm just recovering from surgery. Otherwise, I'm a mom of 2, and I'm a physician. That's about it. Thanks for having me.
Thanks so much for coming on. So glad to see you on Zoom versus our social media post or talking on the phone. Thank you for joining. I appreciate your support.
Yeah. Thanks, Tracy.
Let's see, who else didn't go? Jasenia?
Can you hear me?
Yes, go ahead.
Hi, I'm sorry, I'm not where I can open my video right now, but my name is Yesenia. I live in Miami, and I am a breast cancer survivor. I was treated 2 years ago, hormone receptor positive. So I'm on hormone blockade.
Thank you for sharing your story and joining us tonight.
Thank you for having me.
Annette?
Hi, my name is Annette and I live in Charlotte, North Carolina. I was diagnosed with BRCA2, or BRCA2 positive last October, had a total hysterectomy in December, and now am considering a double mastectomy.
Well, thank you for your support and joining us tonight.
Thank you.
Perfect. So what I'm going to do is ask everybody, I'm going to mute all of you guys and we're going to go ahead and get started. So thank you everyone for coming on tonight. My name is Tracy Milgram-Posner. I'm the founder of BRCA Strong, where we educate, inspire, advocate, and empower survivors, survivors, and thrivers to eliminate the feeling of isolation and help you feel whole again. We do this by funding post-mastectomy garments, and during COVID-19, we are sending out packages to women who are going in for surgery, just diagnosed, or if you need a care package, that we're looking to support anybody. So if you or your family need one of those packages, please feel free to reach out to myself, Tammy, or Kate. Tonight, we have a special guest, Dr. Pozo-Kaderman, on to talk about sexuality during and after cancer. Thank you so much for coming on tonight to educate this community, as I know it's such a topic that many of us don't want to talk about. So I do appreciate all of you guys coming on. I know that for me during my journey, sometimes it's just the topic that we all kind of push to the side, but have to remember, for those of us who are in relationships or want relationships, that there is hope. And yes, there is some problems that do occur, but physicians like Dr. Pozo can come on and give us education. So thank you so much for your time and support. I really appreciate you coming on.
Thank you so much for having me, Tracy. So I usually tell people a little bit about myself when I start, and I've worked in the area of cancer for 28 years. So when I started way back, believe it or not, it was before the BRCA gene was actually discovered way back in the 80s. So I remember, you know, when BRCA came about and all that talk, but I worked at Sloan Kettering at that time because that's where I trained, and we had a high-risk clinic going back to the 80s because, again, we had noticed, you know, the high likelihood of these families where there was, you know, breast, ovarian, and we know now other cancers as well that women may be at high risk for. When I started working initially, I did not really focus on sexual health because this was back in the 80s, early 90s, and my training was really as a clinical psychologist to focus on the emotional part of what patients are going through and their families. And I should say that my interest from the very beginning has always been the focus on women. So again, breast and GYO cancers. So after I'd been working for a few years, I noticed that I would ask women when they would come in, and again, I do work with men, but again, I started my work with breast cancer. Women that were being diagnosed with breast cancer. And I noticed they were being referred to me for anxiety and depression. And I was often the first one to ask about any change in your sexual life. And once I asked that question, then I would get often very long answers with more questions. And I realized, this was now about 22 years ago, that, you know, I wasn't prepared to answer. And so I went ahead and then got certified to become a sex therapist in addition to a clinical psychologist. So I wanted to give you a little bit about my background so you know how I came to this. So I know that this group has both survivors, thrivers, and then some women who haven't been diagnosed yet. So I wanted to sort of talk a little bit about the general population. So we know that 1 out of 3 women report low sexual desire. It's a pretty high number if you think about it. And 40% of women report decreased libido, decreased desire during menopause. And we also know that the levels of testosterone of women in their 40s are about half of those of women in their 20s. And the reason I put that up there is because testosterone does have some association with both men and women as the driver for desire. It is not only testosterone, but it is part of what drives desire in both men and women. And so if we're looking at the general population, and these are not women at high risk for breast cancer or ovarian cancer, they haven't been diagnosed, there are some changes, you know, there for women and things that they find that they're not necessarily happy with because they're obviously reporting it even before, you know, any type of diagnosis. I should say, please feel free to interrupt me and ask questions at any time. I'm not used to doing it on Zoom. I mean, I've been doing it for the past 5 months, but it's hard because I'm used to there being a lot of interaction. You can always just put questions and then I can answer them at the end. So when we talk about how somebody is doing sexually, you know, really it's not one talk. It is many talks that I could give on it because it is really complicated. Our sexuality is dependent on so many different factors. So when I see a woman, I don't just see her and focus in just on one thing about her. It's who is she as a person? What treatments has she received? And we'll talk about the cancer treatments, medications, fatigue. We all know the slide before, you know, desire is low for women in the general population. Well, I think part of that is just the fatigue and stress that we all feel. Even before people ever get diagnosed with cancer or BRCA positive, you know, if you are young, you know, you've got little kids, you have a job, you have things to do, you know, when you start thinking about being sexually intimate, sometimes if you've been in a relationship for a long time, you really have to find the time because again, the daily stress. During the pandemic, we don't have a break where some of us home all the time, some of us trying to go to work in a very high stress situation. That's all going to interfere with you being sexual. It's hard to sort of feel sexual and sensual when you're so stressed out. And that's, again, before talking about anything about cancer. Obviously, there's cultural factors, and I always have to take that into account when I see women. You know, different cultures look at sex and intimacy different. Different cultures look at a surgery or removal of your ovaries or very differently than other cultures. And so very important. And what are the woman's religious or spiritual beliefs? That may have had an impact on their spirituality before they were ever diagnosed. So these factors to me are just as important as the medical part. And again, when I see people, I see women, you know, individually. So I'm giving you a general talk, but again, it's very individual type of therapy. We obviously know that through, you know, whether it's cancer or even just pre-existing pain, back pain, that's going to interfere. It's hard to be sexual when you're in pain. How do you think about your body? What are, you know, we know that women struggle with body image and that's going to impact her sexuality even before cancer. You then get diagnosed with cancer and, you know, if you have breast cancer, you lose a breast, you may have reconstruction, you have surgery, you have scars, lose your hair, you gain weight, you lose weight, you know, all that. You know, then are you in a relationship and what was that relationship like before, you know, the diagnosis? And again, I've seen relationships that have become stronger after a cancer diagnosis. While the sex and the intimacy changes, the relationship becomes stronger. But again, it depends on all these other factors going in. And then obviously the psychological factors. We know, and this is sort of how I started off, I was getting women referred to me for high levels of anxiety and depression. And if you're really anxious or you're depressed, it's hard to feel sexual and sensual. Very difficult. When you're fighting for your life and when you're initially diagnosed, the main thing you're thinking about is, I want to live. I need to go through treatment. I need to do these things. At that time, you know, sex is not on your mind. And if you're struggling with your mood changes, again, unlikely that you're going to feel very sexual. I usually tell people that what I think is that one of the most common side effects of all types of chemotherapy, regardless of your sex or your gender, regardless of your age, is that there will be a change in your sexual desire. And so one of the early cases that I got was a young man. And that young man was about 28. was diagnosed with cancer. He came to see me, and for depression, I started asking him questions. And what I very quickly and soon discovered was that he had lost sexual desire. And this was a 28-year-old young man with lymphoma. And he told me, you know, if I'm not going to have my sexual desire come back, I'm single. A big part of my life is being attracted to women. If this isn't going to happen, yeah, I'm depressed. And, you know, I'm really questioning, why am I even going through this treatment if this is going to be the rest of my life? So I told him, you know, it's common during chemotherapy, regardless of the chemo, to have a decrease or a loss of sexual desire. And that should be one of the side effects that's talked about, just like possible nausea, possible hair loss, possible change in your sexual desire. Important to talk about that as well. You know, I told the young man, you know, if it doesn't come back 6 months to a year after treatment, come back and see me. Stop in the waiting area, saw me, and just said, you know, I'm back, no worries. That's why I didn't come back to see you. So again, it applies to all types of cancer, and regardless of age, gender, it can affect your sexuality. I'm going to ask if anybody is unmuted to please mute. Thank you. So medications, we definitely know, as I just mentioned, that chemotherapy obviously can have a big impact because it affects your fatigue, your energy level, how you look. And so we know that it has an impact on desire. But there's other medications that people may be on, whether you're diagnosed with cancer or not, that can have an impact. And so if somebody has thyroid difficulties, that is very likely to affect your sexuality. And so somebody who's on Synthroid, if people have are on any type of antihypertensive or medications for high blood pressure or diabetes. Hi, is that a question?
Debbie.
If you can mute, please. If you can please mute, thank you. Okay. So diuretics is not something you'd think about. Should I?
No. He's in here.
Okay. I don't know. Yeah, somebody's just, I just wanted to, because I don't know, but somebody, okay.
Hold on. Yeah, let's see if it happens again, because there's everybody's muted.
Yeah.
So let's try again.
Okay. So diuretics are one of those medications you don't necessarily think about, but what do diuretics do? They make you, you know, expel, you know, fluids and urinate. And what is that going to do? It's going to dry you up. What do allergy medications do? They dry up your mucous membranes. And what is your vagina? A mucous membrane. You know, obviously antidepressants can have an impact. It's interesting. A lot of times people say, but then why would you take antidepressants? Well, antidepressants, and we'll talk about this a little later on, will actually usually increase sexual desire if somebody's depressed. They can interfere with ability to have an orgasm and delay that, but not necessarily with desire. Obviously, pain medications can have an impact on how you feel sexually, and alcohol. Alcohol is a tricky one because people will say, well, alcohol will relax me, and it does, but then what alcohol can do is that it makes it harder to have an orgasm. So again, it's sort of a tricky one. But what I wanted to point out there is that before you ever get to a diagnosis of cancer, there's many factors to take into account that may predate the cancer diagnosis that are important and that I really think are a critical component of when I see somebody that I take into account. Now, when you look at breast cancer, people sometimes say, well, these slides are old. Yeah, they are, but nothing has changed because so many of the treatments for breast cancer haven't. So, you know, if you're getting adriamycin and Cytoxan now, if you're undergoing many of the chemos, Taxol, you know, Taxotere, it's going to be the same. So you can see in this slide that after going through breast cancer treatment, and particularly going through chemo, you know, most women will report some type of change in their sexual desire. Usually desire, and then often painful sexual intercourse, which of course leads to desire, to decreased desire. It's hard to feel sexual when you've tried to have sexual intercourse and it's painful, right? I mean, who wants to do something that brings about pain? One of the other things that's always been talked about, and early on, the thought was, if women had a lumpectomy versus a mastectomy, would they do a lot better emotionally? And I think this is because these studies were done in the late 80s. And at that time, most of the researchers were really men. And the thought was, if you don't remove the breast, then all of a sudden women are going to be do psychologically a lot better. But you know what? The studies have shown clearly that that is not the case. Whether you have a lumpectomy or a mastectomy, your psychological distress is the same. Because what matters is that you got a diagnosis of cancer. And so your worry about recurrence and all those fears are the same. The only place that there is a difference is in body image. Lumpectomy patients report a better body image because they're able to maintain often, not always, some sensation. But again, this has to do more with body image. If you look at gynecologic cancer, then again, you'll see that whether it's ovarian or cervical or endometrial, you're going to have high reports of a change in sex life. And again, not always for the better. And if you're looking at endometrial or cervical, it really seems to be the radiation that brings that about. I don't probably think that in this group I removed the slides on cervical because I didn't think that was big on this population we're meeting. And that would be a whole sort of separate set of slides that I include there for those particular patients when they go through radiation. So this is a slide from 1997, and I keep it because if you ask women today, you would still get the same thing. Women are not being asked about their sexual life, with some exceptions. Obviously, there are some oncologists that do, but for the most part, it is something that is not talked about. And the reason it's not talked about, I think, are several separate reasons. I think one has to do with first of all, it's not the focus of the treatment or the diagnosis, it's surviving. And so it often becomes more of an issue later on in the treatment course or in the survivorship journey. And what happens is that oncologists are busy, and then also they start to wonder, if I ask and I get a whole bunch of questions, what's going to happen if I don't have the answer? And that's, I think, where people then sort of shy away from these types of conversations because they don't feel that they have an answer or somebody to refer to. So I'm going to talk now more specifically about breast, but this applies to ovarian as well. If you're a menopausal woman and you're diagnosed with breast or ovarian cancer and you've been on some type of a hormone replacement, be it a patch, you're going to be asked to stop that immediately. And so menopausal symptoms will often return. If you are premenopausal before your diagnosis, well, obviously, if you're diagnosed with ovarian, which is usually more commonly, you know, after menopause or closer to menopause, but if you're premenopausal and you get diagnosed, chemotherapy has a high likelihood, depending on your age, on the dose of the agents and the type of chemotherapy agents that you're on, to be permanently put into premature menopause. And you can look at the numbers there. If you're under 40, you know, and you get something like Cytoxan and Adriamycin, you have maybe less than a 40% chance of becoming, you have a greater than a 40% chance of not becoming menopausal. But if you're closer to your natural menopause, meaning usually about 52, then your chances of becoming menopausal go up a whole lot more. And if you're on something like tamoxifen, again, you know, irregular menstruation, an additional 20% stop. And it's sort of interesting for some of the menopausal women, There is no thinning of the vagina necessarily, and there's sometimes some discharge, and it is often associated with less likelihood of actually having vaginal dryness for some women. Again, I qualify, none of the things that I'm talking about apply to everybody. They're just possible things that may happen to you, possible side effects. You know, the aromatase inhibitors, we know that that can bring about decreased sexual desire. And for so many of the women, what they tell me is that they're fatigued, they have joint pains and aches, they just don't feel good. And so it's hard to feel sexual and to feel good when you're just not feeling good overall and your body just doesn't feel good. Again, often these things are associated with weight gain. And so another sort of, I think another thing that happens to your body to affect how you feel about it. So when you go into menopause, whether it's premature or you're in it and then you stop taking medication or you get your ovaries removed, you go into menopause. And that results in a decrease in estrogen and testosterone levels in your body. Now, obviously, that can have many effects throughout your body, but I'm only going to focus on the ones that can have a direct impact or are most likely to have a direct impact on your sexuality and your mood. So those would be hot flashes, vaginal dryness, which is pain, tightness, changes in mood. I do have a lot of women that will say to me that when they go into menopause or even premature menopause, they notice a change in their mood. They're more irritable. They notice that they're more anxious. They're more weepy. They cry easier. Some women have described it as sort of being in a chronic PMS type of thing. Fatigue is common, sleep difficulties may be related to the hot flashes. If hot flashes are bad, often, you know, not only due to menopause, but for example, tamoxifen, then that's going to interfere with your sleep. It's going to bring about fatigue, and that can affect your mood. And then, of course, when testosterone levels go down and estrogen, there may be some decrease also in your libido, your sexual desire. Why do I talk about hot flashes? Because hot flashes really can interfere a lot with your mood, your energy, your sleep. And if you're not sleeping well and you're waking up several times a night, that's really going to have an impact on how you feel during the day. You know, some women have described to me that they're sweating at night and they have to remove their pajamas. Even if they sleep without any clothes, they find that their hair becomes drenched and, you know, it affects them and they wake up. So again, it's hard to feel sexual when you're sweaty and not feeling good. And it will affect you during the day. So these are some of the things that we've talked about, and that there seems to be some possible research to back it up. We definitely know that exercise and relaxation and meditation can be very helpful for hot flashes, and then they can help you with your sleep, with your mood. Probably one of the areas that there's the most research to back up exercise is mood. It helps greatly with anxiety and depression. Diet, we know that having a healthier sort of, you know, eating more fruits and vegetables, that type of diet can be very helpful in terms of decreasing hot flashes. There's a lot of herbs out there. Now, I'm not going to comment about the specific herbs because research hasn't been able to show any specific herb that is helpful, statistically better than placebo. But I should say that placebo is usually about a 30%. So it's hard for a lot of treatments to be better than placebo. So with the herbs, what I usually tell women is to make sure you discuss it with your oncologist, because you know that Taxol comes from the bark of a tree. So we do know that a lot of drugs that can be very powerful come from plants. So just because it's an herb doesn't mean that it doesn't have an impact on your treatment. But if you get it cleared and that particular herb helps you with desire or with hot flashes or whatever may be, whether it's primrose oil or black cohosh, then go for it, because as an individual, it may help you. I listed here acupuncture because I do routinely refer women for acupuncture. We have acupuncturists at most of our major cancer satellites and Sylvester, Maine, and they're specifically trained to work with cancer patients. So I do refer them. And then as an individual, what helps you? Maybe caffeine, alcohol. We know that red wine can make you flush. You know, maybe people who smoke shouldn't do it, but if you do, that's going to increase, you know, hot flashes. And individual triggers, you know, for some people, it may be spicy foods. For other people, they tell me that if they don't wear natural fibers. So again, look for yourself. Staying hydrated, carrying a water bottle and spraying yourself. And then one of the things that I wanted to bring up is that the best mechanism to manage severe hot flashes that interfere with functioning is antidepressants. You have to be careful, and you have to use certain antidepressants only, like Celexa or Effexor, because some antidepressants can interfere with the metabolism of tamoxifen. But if you take something like Effexor or Celexa, you speak with your doctor, your oncologist, they really do reduce hot flashes. And in the process, they may help your mood, they'll help you sleep, they'll increase your energy. And often the therapeutic dose for hot flashes is lower than the dose you need to take if you're really very depressed. The biggest predictor of sexual dysfunction, and you can look here, is vaginal dryness. More so than emotional well-being, more so than your body image, more so than the quality of your relationship. If you have severe vaginal dryness, or even not that severe, if it's vaginal dryness, that's going to interfere your sexual functioning, particularly if you are in a relationship where intercourse is a major part of how you get pleasure and how you are intimate with your partner. And I say this because one of the key things I work with couples is to really explore various ways of getting sexual pleasure that don't always rely on sexual intercourse. But again, because that often seems to be pre-cancer diagnosis with so many people focus on. And again, that's variable depending on the relationship. What is vaginal dryness? Obviously itching, burning, irritation. And then I have a number of women who tell me that they'll have bleeding after sexual intercourse, and it's really painful. And that's going to happen because what happens is you are losing the elasticity of your vagina. And so that elasticity, when your estrogen levels get really low and are non-existent, you are losing that elasticity. And the walls of your vagina are dry without having the lubrication. And so, of course, when there's any rubbing, you're going to hurt. It's going to hurt. And the vaginal lining gets thinner as time goes on. Even if you have, go through regular menopause, those changes happen. But when it's premature and it's done abruptly, whether it's through surgery or chemo, it happens quickly, and it's going to often feel that much worse for women. So what can you do here? So this is the two things that I tell women. You're going to need to do two things: moisturizer and a lubricant. So the moisturizer needs to be a part of your regular regimen, whether you're in a relationship or not, because if you've gone into menopause and you're not taking, this is even for women that go through regular menopause and don't want to take hormone replacement or don't want to use a patch, this is menopause. Your vaginal lining will get thinner and you will not have as much lubrication as time goes on. So you need to use some type of a vaginal moisturizer. This is, again, regardless of whether you're in a relationship or not. And the vaginal moisturizer needs to be used like any other moisturizer that you would use for your skin. It needs to be used every other day. And I usually tell women, make it a part of your routine. Do it right before bed. Why right before bed? Because you're going to put it in your vagina. And it's a liquid. And so if you put it in and you start walking around, it's going to leak out. Now, what I personally like are Replens. That's what I like as a moisturizer. This, again, has nothing to do with whether you're going to be sexually intimate or not, or have intercourse. This needs to just be part of your routine. Wash your face, brush your teeth, put on your facial moisturizer, put on your vaginal moisturizer. As I said, I like Replens because it's water-based, it's natural feeling, and there's different ways you can get it. This has no hormones in it. It is over the counter. And again, the price is pretty reasonable. It's available at Walmart. It's available on Amazon. And you can buy it where it's pre-filled applicators, or there's an applicator that you just fill yourself, which is what I like, because the pre-filled applicators often have too much and you're spending extra money, and a lot of it is coming out in the morning. Now, if you're gonna be intimate, you will wanna use then a lubricant, okay? You're gonna use a lubricant, and you need to use a lubricant because that is gonna definitely help you. And the lubricant is not only used on you internally, it is used on you externally around your vulva. If you are in a heterosexual relationship, you are going to put it on your male partner's penis. You need to really use that lubricant. I like Astroglide, it's water-based, there's many out there, but again, I would say use the lubricant as part of your foreplay. Include it as part of foreplay, and it may need to be reapplied. Now, some women have said to me, you know what, I don't really like, it takes away the spontaneity. Again, I really say make it part of your foreplay, but if you really feel that way, there are suppositories you can insert and that do melt.
We have a question, Dr. Pozo.
Oh, go ahead, of course.
Hi, Dr. Pozo. I was wondering, are any of these suppositories or lubricants, I guess, homeopathic? I use the Key suppositories. I like it well enough, but I don't know if there's anything that's a little bit longer lasting, but still homeopathic and doesn't have any kind of chemicals in it.
I know. Well, that's why I like Astroglide, because it is sort of, you know, water-based, but the ones that I have here do have chemicals. Now, I will tell you, there is a company that has, let me look it up because now I'm forgetting. There's a company that puts out several different herbal, and you can look into it. Let me see if I can find it now. I'll look it up, and by the end of the talk, I'll give it to you. And again, I'm very flexible. You know, some women say they like to use coconut oil. If people want to try different things, they can, because they feel it's more natural. I just sort of list what I tend to suggest. But again, if something works for you, definitely go with that, you know? And so again, you know, there's other things that can be affecting. So as I said early in the talk, you know, check your medications, avoid feminine hygiene sprays, perfume soaps, deodorant panty liners. All those things cause irritation. And a lot of the women tell me, you know, that, you know, not only is it uncomfortable related to sex, the vaginal dryness, it's uncomfortable sometimes if they wear tight pants, if they ride a bike. I mean, it's just uncomfortable. And that's why, again, I'm listing all of these things, because I think it's important to look at it, again, going along with your holistic comment, to avoid as many chemicals as possible, you know, in your vagina area, as well as your vulva and just your whole genital area. Obviously, you know, some of the women will say to me, you know, have I gone into menopause? So, you know, you want to speak with your oncologist. Have you gone into menopause? You know, sometimes when I give these talks, you know, there's women who haven't yet, you know, been diagnosed with cancer. And so they'll say to me, you know, what about hormone therapy? You know, estrogen cream, tablets, ring. Okay, so let me go with the first one there, estrogen cream, tablets, or ring. What I usually say there is anything you do with hormones, you have to discuss it with your oncologist. That has to be done. I will say that of those, the cream, the tablet, the ring, the cream has shown to have the least likelihood of it being detected if you get blood work done systemically. So when you use a topical estrogen cream, it is not very likely, if you get blood work done, that it's going to show up systemically. With that being said, you can't do anything like that until you talk to your oncologist. And I always say, you know, it's very important to make sure that you've tried other things as well. I put their testosterone patch. It is not approved in the United States for, let me see if I have, let me just look really quick if, what's the next one? No. Okay, so the testosterone patch I put there because there were studies done. The thinking being testosterone deals with desire. So what about a testosterone patch for women's sexual desire at lower levels than you would ever give a man? And what's really interesting is that it was not FDA approved. And the reason was that the testosterone patch was no more effective than a placebo patch for desire. So again, it goes back that sexuality, intimacy, you feeling sexual is so much more than a biochemical. Part of it, yes, for the lubrication, obviously, but for the sexual desire, which is what the testosterone patch was meant to have an impact on, it did not. It was no better than a patch. Now, I put here medications. Let me see if I do that later on. Okay, I'll talk about medications a little bit later on. Fatigue, a lot of the same things we just talked about. If you're fatigued, you're stressed out, you know, the last thing you want to do at the end of a night. So part of it is really pacing yourself, finding out, you know, a lot of women, when I bring in the couple, because I often see couples, you know, I find out, yeah, who has interest in being sexually intimate at the end of a day? Maybe it's better to do this on the weekend at the beginning of the day, you know, setting aside time for it. And I would say that even before you're ever diagnosed, going back, you know, you need to make time to be intimate with your partner, because if you don't, it's easy to get caught up in the daily stressors. So again, pay attention. Are there times when you notice that you're more energetic? You know, music can be very helpful in desire. You know, we all have associations with certain types of music that may make us feel more sensual. They bring back times in our lives when, you know, we associate with our youth, or music that makes us feel more energetic. Again, acupuncture has been shown to help with fatigue. You know, so make sure you do things to take care of yourself so that you can be more in that place to feel sexual. Whether, again, I list there tub baths and all different types of things. Body image, that's an entire talk. I mean, I can do an entire talk on the changes of body image due to cancer treatment and going through treatment, even if you don't have cancer, but you go through prophylactic mastectomy. I mean, that's a whole talk. So much of it really has to do with the woman. I very often will bring in the partner. And when I talk to the partner, they'll say to me, I still find her as beautiful as ever. I don't really notice this change that they're focusing on. I'm just happy they're alive. I would love to be intimate with them. I don't ask more about it because, you know, I don't want to be insensitive. I don't want to hurt her. But you know what? I still find them as beautiful as ever. And I tell them. But you know what? It's the woman that has to feel good about themselves. And that's you that you need to do that. And so that's why this whole slide really is an entire talk. Because even before ever being diagnosed with cancer or BRCA, you know, we're often our worst critic, and we're so hard on ourselves, and we're so often not comfortable with our own bodies. And then you get diagnosed with cancer or BRCA, you go through treatment. And so then, you know, it's more insult to your body and your sense of self. So again, exercise just is one of those things. And I listed there, I really, when I work with women, I ask them to go shopping and maybe get new clothes, think about things that trigger them, that make them feel more sensual, and really focus on getting comfortable with your body. But again, as I said, I have an entire talk on body image. So now that what I listed there were, you know, medications or drugs. So this is really interesting. Marinol, as you know, is often used to treat nausea and vomiting. And it's sort of marijuana in a pill form. And this was really interesting. I noticed many years ago that I had a woman who was prescribed Marinol. She was a young woman, breast cancer. She was 38. And she noticed that when she took Marinol for nausea, she became very sexual, and her husband was thrilled. And she was like, what is this? And so we started talking, and she had always associated smoking marijuana with sex. And she found that since her youth from college. So I started saying, you know, and I had people sort of talk to their oncologist and try Marinol. No study, you know, and I should probably put a little question mark. Oh, let me go back. I should probably put a little question mark here on it because, but for some women, I've noticed that if there's that association with marijuana, sometimes, you know, they may find that that helps them to relax and makes them feel more sensual. Again, I don't know how much of that is individual, right? Be interesting study maybe at some point. Viagra, Levitra, Cialis, you know, early on, those are the ones that are used for males for erectile dysfunction. And you know what's really interesting? They really thought initially maybe it helps women. The studies have not shown that it does. It does increase the blood flow to the genital area. And there are some women, interestingly enough, that will report that they feel maybe the orgasm more. But again, who knows? While the studies may not show it, what I keep saying here is placebo is 30%. So it's very hard to know because some of these things as an individual may help. So again, it's things to think about. Wellbutrin is an antidepressant that's often used to treat the side effects from antidepressants on difficulty having an orgasm. And Wellbutrin is the drug that for some of you that are older, you may remember that there was this whole thing that some patients were taking an antidepressant and were having spontaneous orgasms. It was Wellbutrin. That doesn't really happen often, but again, it does help with having orgasm. So if you're on an antidepressant that is delaying your ability to have an orgasm, that would be something that your psychiatrist, your primary physician you can discuss. Buspar also to treat antidepressant side effects, not as good sort of as Wellbutrin. And then I listed here some medications. The reason I listed these new medications is because I get these questions asked all the time. And I knew that some of the women that would be here on this talk may not necessarily been diagnosed with cancer, may just be at risk, and I sort of wanted to address some of those. So one is Osphena, which is actually a SERM. It's a selective estrogen receptor modulator, like tamoxifen. And so it is used to treat moderate to severe vaginal dryness, pain during intercourse. It is not really used. It came out really not for breast cancer patients necessarily at all. It really came out as something to use for menopausal women who were complaining of vaginal dryness. And so the side effects are pretty much the same as you would get with tamoxifen. You know, the hot flashes, vaginal discharge, excessive sweating, you know, again, just like tamoxifen. So remember that I said to you that for some women that are postmenopausal and that have menopause, vaginal discharge is often one of the side effects of tamoxifen. And the thinning is not associated with tamoxifen for postmenopausal women. So again, this is something, it's not something that's that great. It's only 14% better than placebo. But again, I wanted to bring this up because I get asked about this often when I see women. Something else that I get asked about, which is for low sexual desire for women premenopausal, is Adiyi. And this was initially developed as an antidepressant. And what they found is that it wasn't a great antidepressant, but some women reported more sexual desire. I show you there the comparison with placebo. It's not a lot more than placebo. You see there the numbers on the slide, but you know, there's so little out there for women's sexual desire. You know, this is only women, so I can say this. It's like men get everything, you know, they get all these drugs. For women, there's so little. And none of these things are being developed with the focus, it just comes out as sort of like, oh, we noticed that some women on this antidepressant reported a little bit more sexual desire. It's not a good antidepressant, so let's give it a try. The main problem with this is that it interacts with alcohol. So even one glass of wine can reduce a woman's blood pressure, and it is associated with dizziness, sleepiness, and some women get very low blood pressure and can pass out. So again, it's not a great drug. That's why it isn't being used. It's not like the new Viagra. And the reason is because the side effects are not great, and it's not that much better than placebo, which again, I'm reiterating the point that sexual desire is so much more than just biological. Sexual desire involves so much more than that. It's really about so much more. So, and here's the testosterone information. So again, no benefit from the testosterone patch. So what I'm gonna say here is that exercise, physical activity, so many other things are so much more important to you feeling better about yourself. There isn't this great pill that's just gonna fix it all. I think that we're much more complicated. And so I'm gonna just go quickly through these last two slides. You know, sexuality is something that is spiritual, it is emotional, it involves so much more than your body. And communication with your partner is gonna be key. If you look at this as only something that you're doing, it's just not gonna work. You really need to communicate. And from the very beginning, if I see somebody and they're in a relationship, I'm gonna bring the partner in. To dispel myths and misconceptions, because often partners will say, you know, I thought they no longer loved me, I thought they weren't interested in me, I didn't want to bring it up, I didn't want to upset her, I didn't want to hurt her. So again, communication. And I really think that during this time period, you know, focus more on just being with your partner, getting comfortable with yourself and with your partner, whether that means, you know, to listening to music and dancing and kissing and holding hands. You know, while you may not be in the mood necessarily for sex itself, you know, most people enjoy being touched. So maybe just start doing that. So often the focus, particularly in heterosexual relationships, the focus is on intercourse. That is the be all end all. And you know, that has to, what I usually say is, you know, let's take a step back. Let's just focus on being comfortable with each other and, you know, relax, take a shower together, a tub bath, sensual massage. I mean, sort of go away from that focus on intercourse. Focus more on your sensuality. You know, watch an erotic movie, read erotic literature to each other, even to yourself, you know, get to know yourself a little bit more. You know you're gonna need extra time for foreplay, the touch should be gentle, but you know what, maybe even before with a partner, you may wanna try, you know, with yourself, going back to this, you know, just get to know yourself, read erotic literature, see what turns you on. You know, some women tell me, you know, I've never really given this much thought to it before. Now, because I'm not able to get pleasure in the way I always did, I'm having to explore new things. I'm having to talk more with my partner. And so be open to new ways to explore and to get pleasure. You know, different positions, be willing to experiment, you know, use a vibrator. So when I say different positions, we do know that often what is called the missionary position with the man on top and the women, you know, laying down really doesn't give women much feeling of control. And if you've several times tried to have sexual intercourse and it was really painful, you know, when you see your, you know, partner and this right above you and going to penetrate, you're gonna automatically tense up because it's been painful. And so, you know what? Now that's gonna add, that anxiety is gonna add. You know what? Be on top. Now you can control the penetration. You have control over it. So again, explore new ways. You know, vibrator, self-stimulation, mutual stimulation. you know, again, it's being open, communicating. If something hurts, communicate ahead of time even, and sort of say, you know what, my breast, you know, is numb. It's not painful, but it's numb. I really prefer not to go there now. You know, it's sort of have these conversations so that there's more relaxation. You know, really be patient with yourself. And as I said before, and I repeat, intimacy is not just physical. It's really emotional, spiritual, and it's a connection that you're having with your partner on so many levels. And I know, because I've worked so many couples, that while it may not be the same as it was before, and it's often very different, it could still be very, very fulfilling. And keeping sex in perspective, because it's one aspect of your relationship, but it's all about that intimacy. So I know I spoke fast and I tried to get a lot in the 45 minutes, but you know, I'm open to questions and any comments. And thank you so much for listening so patiently. It's so hard because there isn't that interaction. So thank you for being patient and listening.
Thank you so much for coming on, Dr. Pozo. I greatly appreciate your lecture and educating the girls. What I'd like to do is open it for Q&A. If anybody has questions, if you guys want to raise your hand, you can feel free to raise your hand in the here, or you can go ahead and type it in the chat. So go ahead, Tammy, you want to open it up?
Yeah, so for those of us that have ovarian cancer survivors, or, you know, there is definitely like and hysterectomies, and if you have the BRCA gene, you can't really take hormones. Right. So how are you, you know, and I, like me personally, I'm not in a relationship. So when you're not in a relationship and then you have no desire, and then there's this fear of pain because of the, you know, because of the ovarian cancer, I see like all of the things that you're saying to do, but a lot of them require medication.
Yeah.
And a partner, but and hormones. So if you can't take hormones,
no, but actually my first slide was that the first thing I tell everybody really is to go with a moisturizer. And I mean, I'm postmenopausal now, and so that's just part of what I have to do. You know, if I don't want to take, you know, hormones, I have to use a vaginal moisturizer, because whether, you know, that's for any menopausal woman. So I would say I personally like Replens, but you need to find what works good for you. And I think it's hard. I'll be honest with you, it's hard because I forget to use it, and I forget to use my facial moisturizer, right? So it's partly making it a part of your routine. And it is hormone free. The moisturizers that I'm talking about are all hormone free. Okay. So it's making it a part of your routine, and it's tough. Like I said, it's hard to just incorporate that. You know, one other thing that I do talk about too, and I think I had it there, is Kegel exercises. And if you go into menopause, you know, it is good to talk to a physical therapist who specializes in, you know, pelvic floor exercises. And U of M has 3 of them, and they're wonderful. So, you know, with menopause, you get other things, right? So, you know, you get, you know, there can be some incontinence and other unpleasant things. And the pelvic floor exercises can be very helpful. And so I would say that if your insurance has physical therapy, you need to find somebody who specializes in pelvic floor.
Thank you.
No, thank you for asking.
Let's go ahead. Suzette, you want to go?
Hi. So I had a lot of trauma I had 2 cesareans. I have two children, and then the surgery for cancer was very invasive. So I did seek out a pelvic floor therapist, and actually that was my question was, so, because now that I'm, you know, I went through that, I've done during COVID, since it was kind of closed and nobody was going, like I went to her, I was able to do it calmly, and I was able to kind of like get through it, and she was very helpful. She does a lot of myofascial release, and that was really helpful. But knowing that I'm gonna have more trauma again, I'm kind of at a loss, because I'm possibly even losing my vagina at this point. So I'm just not sure how to like.
I know. Yeah. Yeah. I mean, again, you know, do you see somebody at U of M? Or you
I'm
at
seeing, she's an individual physical therapist with connected, I think, with Baptist.
okay.
But
Because I was going to say, you know, really that, you know, and I do see women, and I have seen women who've lost their vagina. I've seen women who have vulvar cancer. So I've seen all of that. And really, it's about working with your partner, right? And it's not something that's going to be easy. And I don't have a slide for it, you know, and an easy. It's something that I would say, you know, I've worked with couples. And again, it's finding different ways to be able to still be intimate and have pleasure. And that can happen, you know, even with women who have, you know, vulva cancer. So it's finding it. And so I hear you. And this is a scary time. I hear what you're saying.
Is there any research, because they're talking about doing a chemo bath in the middle of surgery, which I know is really long, and you know, I guess they're trying to avoid the chemo afterwards. And this is such an aggressive cancer. I mean, they really thought that this was not coming. Like I was one that was in the clear, but it's obviously, you know, probably not. So I don't like, is the after for a chemo bath different sexually, hormonally than traditional chemo, or is it?
No, because you've already been through chemo.
Yeah.
Yeah, so I don't think that this is going to do anything different than where you are right now, right? And you already had your ovaries removed, right?
Yeah.
Yeah. So I think that this is more, it's a localized, you know, treatment in your abdominal area. And that's, you know, from what I know, that's often done for ovarian cancer. And, but I don't think in terms of the sexual realm, that would be anything over and above, you know, that for you to be concerned about. Now, obviously, as you just brought up, you know, if they remove your vagina, well, then yes, obviously. But again, that would be communication with your spouse. And I know, I see you're young. You said you have kids, right?
Yeah, I mean, 16 and 18.
Yeah. So again, I think that's where, you know, working on that after you get through your surgery and you start to recover, and working with somebody and your partner on that. Yeah.
Thank you.
One question came through the chat, and then I'm going to turn it over to Kamali. Do you have any experience working with Mona Lisa?
I have. I've heard from people that they really find Mona Lisa very helpful. And then other people say they don't, right? So again, I should have probably put that on the slide. Some studies really seem to show that it can be very, very helpful for the lining of the vagina. And if that helps and that's something that you decide to pursue, I would say go for it. Because I do have a number of patients who've done that, and I need to add that to the slide, I forgot, that do find that the Mona Lisa really helps. Yes.
So as you touch base on it, something came through, and she's asking, she's from South Africa. Maybe if you can elaborate just a little bit on the Mona Lisa.
Well, again, you know, I'm not a physician, but it's sort of like a type of treatment that they do that uses, and it's not really radiation necessarily, but it's sort of what they do is work on your vaginal lining to sort of, I don't know the best way to say it, but it's sort of like, you probably can say, Tracy, it's, you know,
so it pre-lines your mucus of your vaginal wall. So basically they go in and it's done with a
laser,
and they inject it. It's not painful. And they reline your wall. So as you're sexually active, you basically have mucus in that area. So it's not dry and painful. It's not really FDA approved yet. They're working on FDA approval. It's been around for a long time. And if anybody has questions, I'm more than happy to talk about it offline. You guys can reach out to me and I can guide you through it. I know a lot about it. I've worked with it for several physicians as well.
Yeah, people who get it really, you know, say that it helps a great deal. It's a laser, it's not painful, and they notice that they do get benefit afterwards. So again, you know, again, just because something isn't FDA approved doesn't mean it doesn't work. And as an individual, it may work for you. So yeah.
Anything, if anybody has questions, you guys can feel free to reach out to me. Either we'll stay a couple minutes after, and then if you guys have questions, I could elaborate a little more. Kamali?
My last two questions, I promise, quick questions. What is your thought, doctor, on dilators? And secondly, how does one kind of relax their partner who feels like they're going to hurt you, so I'm not gonna even touch you?
Yeah, that's the part that's tough. So dilators, I didn't include it in this talk because I usually do in the cervical talk, but yes, I actually, anybody who's gotten, you know, radiation, but even if they haven't and they have some, you know, again, loss of elasticity, I do recommend that you use and you start, you know, there's different sets that you can get, and that you start with a really small and then you gradually increase. And I think that, you know, strongly recommend, and again, we do it routinely with our cervical cancer patients. Actually at U of M, unfortunately, we have a high number of cervical cancer patients through Jackson. We're probably one of the highest places in the country. So we do have many women who go through, and we start them with the vaginal dilators right from the very beginning. In terms of with the partner, I mean, that's again where, you know, he needs the education, right? Or she does, because they're so scared. And so it's saying, you know, I really want, you know, and probably guiding. And, you know, it's sort of hard because often it's the woman that's been through it that has to take the lead because they're too scared and they don't want to hurt you. But again, as I said there, probably starting off with just touching, you know, in a intimate way, sensual way, but not directly going to, you know, sexual intercourse, for example. Yeah.
Is there any other question? Go ahead.
No, I was going to ask if there were any other questions.
Suzette, did you raise your hand? Did you still have another question, or did I come to you already? You're good. Does anybody else have any other questions? Well, I appreciate your time and dedication.
Thank you.
Coming on and helping us educate all the women on the options and knowing the medications and things that are out there. We're truly grateful, BRCA Strong, and look forward to having you back on another night.
Thank you very much, Tracy. It's always wonderful, and you guys do so much to help so many women. So thank you very, very much. Thank you for having me.
Perfect.
Have a wonderful evening. Bye. Bye.
Thank you.
If you guys want to stay behind and have